They were duly recognized by both being awarded the Harrington Award for the fellow of the graduating class who most emulates the qualities of Bob Harrington, our former director. So congratulations to both of them, and I think it was a well-deserved award. I have the pleasure of introducing Matt, and then Brian Smith will introduce Julie for the second presentation. And I apologize that I won't be able to stay because Dr. Granger has me on a trial committee call at the same time. So you can blame him when you see him in the hallways. But Matt has really achieved phenomenal success here at the DCRI. He was born and raised in Hawaii, and his father was a submarine commander in the U.S. Navy. And so he has some great stories about that as a child, and I learned that when we did clinic together for a year. And then he went to undergraduate at Duke Medical School at Emory, and for some reason he decided to go to Brigham and Women's Hospital for his residency, like many of our trainees for some reason. But then they see the light and they come back to Duke. So we're glad that he's back here. And he'll be doing a 2-year interventional cardiology fellowship starting like right now or next week. And Matt has worked, originally mentored by Rick Becker, and then Rick has moved on to the University of Cincinnati, so Kristen Newby has assumed the primary role, but he's worked with many faculty members, including myself, on different projects and has done a tremendous job and has a very robust publications record and a broad swath of different research activities. So today he'll be talking about blood transfusion. I think there's a work with Sunil Rao, one of our interventional cardiologists, and we're really pleased that Matt has been with us for 2 years. We look forward to continuing to engage with him during his time at Duke in the next 2 years. And when you see him in the hallways, just make sure you ask him if he's gotten all of his papers in on time and how he's doing, trying to balance that with a full-time clinical job. So Matt, congratulations, and thank you so much.
Thank you. Well, thanks to Dr. Rowe for that very kind introduction. Today I'm going to talk about just some of the research that I've done in the past 2 years, mentored by Sunil Rao and Eric Peterson. And it involves the use of blood transfusion in patients with coronary artery disease in the United States. As required, here are my disclosures. Because much of the data I'll be presenting today is from the NCDR CathPCI registry, they have their own required disclosures. So first, in my brief allotted time, and I promise to be brief so that I don't talk for 50 minutes and then Julie has no time to speak about her own very important research, I would like to discuss how blood transfusion is utilized in patients with coronary artery disease and how that use of transfusion may affect clinical outcomes in these patients. So first, I plan to show a small amount of data about how anemia and bleeding are still prevalent problems in patients who undergo PCI in this country. And second, I'd like to touch on whether transfusion helps these patients. Pathophysiologically, it would seem that transfusion should help, and how we use transfusion here in America. These 2 points, again, brought me to doing a retrospective cohort project with the NCDR CathPCI registry, looking at transfusion practice patterns and outcomes of patients who underwent PCI in the United States. And finally, I'll talk about a summary of some of the randomized data in this area, as well as future directions of my research. So first, I'd like to present data from a former DCRI fellow, Sumit Subarwal, who was here several years ago. And again, this is drawn from the NCDR CathPCI registry. I'd like to describe that registry briefly here. It's a collaborative effort, a quality improvement effort of the ACC and the SCAI, the Society for Coronary Angiographers and Interventionalists. And it actually comprises over 90% of the cardiac cath laboratories in the United States. So it's a fairly good representation of how we practice cardiac catheterization here in the United States. They collect patient demographic information, hospital demographic information, procedural characteristics, and also in-hospital outcomes, clinical outcomes. As a registry, it does not, it's reported outcomes, they are not adjudicated outcomes, so that's always one of the limitations of this type of data. But again, it's very, very robust data, and it's an extremely large cohort of patients. So as we can see in these 3 panels, bleeding remains a prevalent problem amongst all types, all different indications of PCI. Around the 1 to 2% incidence range in patients who have elective PCI or non-ST elevation acute coronary syndromes, and around 4 to 5% for patients who undergo PCI for ST elevation MI. If you then look at rates of bleeding, and this is data from 2005 to 2009, we can see there's a slight decrease in how much bleeding occurs in elective and non-ST elevation situations, and a pretty steady amount of bleeding that occurs in ST elevation MI. But if you parse that into access site versus non-access site bleeding, it's fairly stable except in STEMI patients where we start to see an increase in non-access site bleeding, mostly because of the medications, the more potent antithrombotic, both antiplatelet and anticoagulant medications we've started to use in these patients. So I think bleeding in the PCI setting remains a problem, and we should be vigilant about it. Why is that? Why should we worry? It turns out in a combination analysis of the Pursuit, Gusto 2B, and Paragon A and B trial cohorts, we can see that if we stratify patients by their in-hospital bleeding events, none, mild, moderate, or severe, and then plot their survival in a Kaplan-Meier curve, and this is 30-day mortality, we can see that patients with the most severe bleeding do much, much worse than patients who have mild, moderate, or even no bleeding. And there seems to be a graded response of mortality to the severity of bleeding. So bleeding has a tremendous clinical consequence in this scenario. What are the mechanisms of harm for bleeding? Well, because I've shown you observational data, I must admit that part of the mechanism is that it's confounded, that patients who are sick are more likely to bleed, and patients who are sick are obviously more likely to die. So parsing out the effect of bleeding versus the effect of patients being sick and being more likely to bleed is difficult, especially in observational analyses. However, severe bleeding can cause hypotension, and in these patients, hypotension can lead to ischemia, and that's critical because that ischemia often results in both transfusion and in reversal of important antithrombotic therapy for patients who are experiencing an acute coronary syndrome. That often leads to worse thrombotic outcomes. But even in mild or moderate bleeding situations, there often is just a temporary cessation of antithrombotic therapy, and that again can lead to worse outcomes. In addition, using transfusion in patients that have mild to moderate bleeding is controversial because we don't know whether that transfusion has a positive effect, is completely neutral, or potentially is harmful to patients. So the next question is, does transfusion really help, and how should we use it? This data, this figure is from, it may not be well visible on the slide, but this figure is from a recent guideline document and indicates that transfusion, like any other therapy we use, has benefits and it also has risks. And the risks of transfusion are not minimal. These days, the risk of having a serious infection from a transfusion is about 1 in 1 million. The risk of having a serious life-threatening reaction is probably about 1 in 10,000, but the risk of fever or transfusion-associated circulatory overload, those things, is about 1 in 100, and they shouldn't be overlooked because they're important, especially if we're using them in patients in which the indication is questionable. So we'll look a little bit at some retrospective data, and this is actually from a Canadian cohort of over 5,000 patients who were admitted to ICUs around Canada. And we can see that there's a certain amount of variability in how doctors are using transfusion based upon the indications of admission to the ICU. And what's striking in this slide, I thought, was that for ACS patients, as seen in the beige or white bar there, we can see that transfusion thresholds are much higher. That is, patients are more likely to be transfused at hemoglobin values of 10 versus patients who undergo trauma, sepsis, or GI bleeding. And we don't know if that's actually beneficial to our patients with acute coronary syndrome. If you then look at other data, again observational, this is from Medicare beneficiaries, approximately 80,000 patients over 65 years of age from CMS data. This paper was out of Harlan Krumholtz's group. Basically, we can see, first, data that I'm not showing you is that they stratified patients by admission hematocrit values, less than 24, 24 to 27, 27 to 30, and so on. And what they saw was when you compared short-term mortality, just 30-day mortality, patients who had anemia did much worse than patients who didn't have anemia. If you then take those patients and look at patients who received transfusion compared with those who did not receive transfusion, and plot odds ratios, you can see that in each of these groups, there is a benefit, at least in these MI patients, to transfusion if your hematocrit was lower than 30%. But there's actual neutrality and perhaps harm in patients who are transfused despite fairly normal hematocrits, 36 to 39 and greater than 39%. This is observational data, so you can't tell why those patients were transfused, but it still is interesting to look at. This data has often been cited as and used for thresholds for transfusion in acute coronary syndrome patients. So this is actually data from Dr. Alexander looking at the CRUSADE registry, which was about 50,000 non-ST elevation acute coronary syndrome patients. And as you can see, we plotted rates of transfusion based on nadir, or the lowest hematocrit during an admission for MI in the group. And so what we can see is that the rates of transfusion increase dramatically once you hit a hematocrit of 30%. So once you're under 30, patients tend to be transfused a lot more for whatever reason. But if we then look at adjusted odds ratios for, again, short-term mortality, 30-day mortality, we can see that there is a group, patients with the lowest hematocrit, less than 24%, who may in fact benefit. They have lower odds ratios for, adjusted odds ratios for mortality. But all the other patients with nadir hematocrits between 24 and 27, 27 and 30, the effective transfusion is neutral. And if we look at patients with a hematocrit greater than 30%, transfusion is actually associated with harm or a greater incidence of mortality. So the question is, should we be using transfusion in these patients, and why is transfusion associated with harm? One last background data slide is that there's tremendous variation, and this is again data from the CRUSADE registry that shows that medical doctors are using transfusion in very different ways. And this is a graph of the percentage of hospitals that are using transfusion, and on the x-axis, the percentage of patients at those hospitals receiving transfusions. And what we can see is that some hospitals utilize transfusion in less than 5% of their patients, some in less than 1% of their patients. And there are hospitals out there that are transfusing more than 25% of their patients. So the variability is very, very broad. Now, part of that variability could certainly be due to case mix and the different patients they're receiving. However, what we will soon show in the data that we collected is that a lot of that variability is actually due to local factors, that is, the hospitals providers are practicing in, and protocols that have nothing to do with patient risk. So with that disparate set of data, there were a clinical guideline document written in 2012 by the American Association of Blood Banks. And they provided data about, or provided recommendations for transfusion in all different settings, but we're going to focus on transfusion in the coronary artery disease setting. So their second question in the document was, in hospitalized and hemodynamically stable patients who don't have acute coronary syndrome but do have pre-existing coronary artery disease, how should we utilize transfusion? And their recommendation was that we adhere to a restrictive transfusion strategy, transfusing only for symptomatic anemia or a hemoglobin less than 8. But as you can see on the bottom of the slide, the quality of evidence for that recommendation is fairly weak. Even more interestingly, is if you look at their recommendation for transfusion in the setting of acute coronary syndrome, we can see that in hemodynamically stable patients who are admitted with acute coronary syndrome, they make no recommendation for liberal versus restrictive transfusion strategies, and they don't make a recommendation about a threshold because there simply is not enough data in which to make a recommendation that makes sense. So we're left with this uncertainty, especially in acute coronary syndrome patients, of what to do. It's kind of under these practices that we, under the guidance of Sunil Rao, Eric Peterson, that we wanted to study this in the NCDR CathPCI registry. So our goals were to determine the variability in use of red blood cell transfusion in patients undergoing PCI in hospitals across America. Then to determine how patient factors are associated with red blood cell transfusion, and finally to determine whether red blood cell transfusion does in fact have an independent association with adverse patient outcomes in this group. So as I mentioned, we use the NCDR CathPCI database. I'll just flip between these two slides. We actually looked at a population between 2009 and 2013 of over 5.2 million patients. And once we excluded patients who underwent in-hospital CABG, patients who had more than one PCI during their hospital stay, as well as any patients missing data on bleeding events, procedural complications, or discharge status, we came to a study population of over 2.2 million patients. Hospitalized at 1,431 hospitals between 2009 and 2013. Of those patients, about 50,000 received transfusion. Again, in the 2 million range did not receive transfusion. The outcomes we looked at, first we looked at primarily transfusion rates overall in the cohort by quarter from 2009 to 2013, and then transfusion rates at each individual hospital site. We also looked at clinical outcomes, myocardial infarction, stroke, and in-hospital death. And as a secondary analysis, we looked at cohorts stratified by whether they had bleeding events versus whether they didn't have bleeding events. And the definition for the bleeding events is the standard used for the NCDR Cath PCI registry, shown on the slide. For analyses, we calculated simple rates of transfusion, but we also used multi-level hierarchical statistical modeling to calculate risk standardized rates of transfusion. And that did two things. We wanted to account for the different patients at risk at each different hospital, but we also wanted to account for hospital level clustering, and that is practice patterns are often dictated by what hospital you practice at. Duke itself has clinical protocols. We have our own local kind of practice patterns, and so that is part of the thing that we wanted to try to adjust for in these analyses. We also looked at patient clinical characteristic and in-hospital outcomes and compared them between patients receiving transfusion versus those who did not. And again, to control for the fact that really sicker patients receive transfusion versus those that don't, we used inverse probability weighting for the propensity for transfusion, and then used logistic regression to compare outcomes and create odds ratios for patients who received transfusion versus those that did not. Finally, a secondary analysis, as I mentioned, we looked at patients with and without bleeding events. We also evaluated this by pre-procedure and post-procedure hemoglobin level. So just a quick, very brief look at our cohort. Again, over 2.2 million patients. Patients receiving transfusion on the right, you can see, are older. They're more likely to be female, and they're much more likely to have multiple medical comorbidities, honestly making them a much sicker population than patients who do not receive transfusion. And just as an illustration, when we look at what we could do with our inverse probability weighted propensity analyses, we can see they don't make them completely similar, but the populations look a lot more similar once we utilize inverse probability weighting. When we're comparing outcomes, we can at least say we've done the best job we could in trying to minimize measured confounding. So the first result that I'll present is that the overall transfusion rate in the cohort is about 2.1% for all patients who receive PCI during this time, and that there's a pretty good amount of variability. There's at least 15 to 16% of hospitals that transfuse less than 1% of their patients, and about 5% of hospitals that transfuse more than 5% of their patients. When we then use the multi-level hierarchical statistical modeling to account for patient risk factors and clustering, we can see that there's still a broad variation in how hospitals are utilizing transfusion, that there are some hospitals still that, despite controlling for patient risk factors and case mix, that are transfusing less than 1% of their patients, and there are some hospitals transfusing more than 6% of their patients. And when we calculated median odds ratios and standard variance, we can see much of the variability is due to hospital site alone. A further illustration of this, if we then divide our hospital sites by their risk standardized transfusion rates into tertiles, the green representing the highest transfusing hospitals, the light blue representing the lowest transfusing hospitals, and then we plot their frequencies of transfusion by post-procedure hemoglobin values for our patients. We can see that our highest transfusing hospitals are using a hemoglobin right around 10 as their kind of threshold for transfusion, whereas our lowest transfusing hospitals really are using a hemoglobin threshold around 8, maybe 9 for transfusion. So definitely different practice patterns. Again, and this is after controlling as much as we could for patient risk factors. And as I said before, a secondary analysis was looking at these patterns in patients who bled versus patients who did not bleed. Across all different post-procedure hemoglobin values, we can see patients who bled had much higher rates of transfusion and were transfused all the way out to hemoglobins of 15 or greater, whereas patients who did not bleed more likely sat with a hemoglobin threshold of around 10 and were much less likely to be transfused. So I'm going to turn over to outcomes now. This slide simply illustrates, again, with the 50,000 patients receiving transfusion and the 2.2 million patients who did not, that patients who received transfusion had much higher rates of all of our adverse clinical events than patients who did not receive transfusion. But when we used inverse probability weighting in our propensity analyses, we then created odds ratios for MI, stroke, in-hospital death, and the composite. And what you'll see here is that after kind of this multivariable statistical analyses, we can see transfusion is still associated with a twofold higher risk of both in-hospital death and myocardial infarction, and a fourfold risk of stroke. If we split those patients into those that bled versus those that did not bleed, patients who bled had slightly less excess risk when we did this analysis. Patients who don't bleed and receive transfusion have much higher risk for any of these adverse clinical events. Again, making us think about, well, transfusion is associated with harm, and it's associated with harm when patients who don't bleed receive transfusion in a greater degree. Our final analysis, again, was looking at, and this slide is a little complicated, so I'll kind of walk us through it. When we look at the same thing, we're basically calculating odds ratios of clinical events, and the clinical events are MI, stroke, or in-hospital death, for patients with, who receive transfusion with no transfusion as a referent. If we then split those patients into their pre-procedure hemoglobin groups, we can see there's a group that had hemoglobins less than 10, a group 10 to 13, a group that's 13 to 15, and a group with greater than 15 before procedure. When we do that, we see a couple things. First, overall, no matter what your hemoglobin is in the overall group, you have increased risk for MI, stroke, and in-hospital death if you received a transfusion versus not receiving a transfusion. But then when we, again, split the cohort into patients that bled versus those that did not bleed, patients who did not have bleeding, no matter what their hemoglobin was, their risk for these events was higher. But in patients who had bleeding and had a pre-procedure hemoglobin less than 10, they actually had an associated benefit of transfusion. And that was kind of a check factor for us to say, there should be a group here that benefits from transfusion, and that group is patients who have a low hemoglobin going into the procedure and have bleeding as a result of the procedure. And so that made us feel a little bit better about our analyses because, as you see, as their hemoglobin rises in patients with bleeding, again, they experience hazard from transfusion. So there are several limitations to our study. First, all of this data is observational. None of the events that were collected were adjudicated. They're reported by sites. And so that's a limitation of any of these NCDR cath-PCI studies. Also, we define the temporal relationship when we get the data, that is pre or post-procedure hemoglobin, post-procedure transfusion, post-procedure events. But the absolute relation between each of those things is not well known because we can't know that looking at this much data. It's not defined in the database. And so that's certainly a limitation of our analyses. As such, the associations that we're drawing between transfusion and adverse cardiovascular events are just that. They're only associations. We cannot infer causality of transfusion towards adverse cardiovascular events. But it certainly makes us think about whether we should be using transfusion for these patients. So in conclusion, we decided certainly there's considerable variation in transfusion practice patterns across the United States, and this persists after adjustment for patient differences. Transfusion levels or threshold levels seem to be different in patients with bleeding versus those without bleeding, and different depending on whether you're at a high transfusing hospital or a low transfusing hospital. And red blood cell transfusion in our analysis was independently associated with adverse cardiac events. And this, again, was important both in patients that bled and in patients that didn't have bleeding. This is consistent with previous observational transfusion data, but as we talked about before, the limitation is it's confounded, that patients that bleed have worse clinical outcomes and patients that have anemia have worse clinical outcomes with coronary artery disease. And that these studies are all hampered by the fact that there's confounding by indication. Patients who are anemic or have bleeding are indicated or not indicated to receive transfusion, and that may have nothing to do with their bad clinical outcomes. But we believe that there's not sufficient evidence to be transfusing many of these patients. So let's talk about, just very briefly, there's very little randomized clinical data about this question. There are 3 trials. The FOCUS trial, published in 2011, looked at patients having hip fracture surgery who had known cardiovascular disease, liberal transfusion strategy versus a restrictive one, and looking at MI, functional recovery, et cetera, at 60 days. This trial actually had a cohort of 2,000 patients, and what they found was that there really was no difference in clinical outcomes between liberal versus restrictive transfusion strategies. That is the largest trial in coronary artery disease patients that we've seen. There are 2 pilot trials that have been completed. The CRIT pilot trial in just 45 patients, so randomizing 45 patients between liberal and restrictive transfusion strategies, the result being in-hospital death, MI, or CHF. And again, in this small trial, there seemed to be benefit in maintaining a restrictive transfusion strategy. But if we look at the trial that Duke participated in, the MINT trial, this is in 110 patients who were admitted with acute coronary syndrome, again, randomized to restrictive versus liberal transfusion strategies. We can see there was actually an excess of 30-day death, MI, or urgent revasc in the restrictive transfusion strategy group versus the liberal transfusion strategy group. So the data are very conflicted. There has been no single study that has enough power to answer the question at hand. And so we think that while our observational data kind of shows us that there may be harm associated with liberal transfusion, there's a lot of confounding present, and there's very little prospective randomized clinical trial data to go on. Thus, until those data are available, right now, PCI operators should really minimize bleeding risk using bleeding avoidance strategies such as radial approach, use of appropriate drug dosing, and using bivalirudin or other drugs that reduce the risk of bleeding. And transfusing only for symptomatic anemia or hemoglobins that are less than 8 grams per deciliter. And finally, this really highlights the need for randomized controlled trials in this setting. As for future directions for the research, first, transfusion variation isn't present just in coronary artery disease patients undergoing PCI. Elliot Bennett Guerrero from this group actually published a great paper on how much transfusion variation there is in CABG patients. In addition, one of the questions I have is there variation in structural heart disease patients? That is, using the STS ACC TVT registry and looking at patients who are undergoing a new percutaneous procedure, a transcatheter aortic valve replacement. This is a very sick group of patients in which there's very little data about how to practice, including antithrombotics, anticoagulants, and in transfusion. So we're putting together a proposal in order to look at this cohort of patients that's around 10 or 12,000 patients so far and see how transfusion is used. As just a hint, and looking at some of the published data, over 25% of these patients are receiving transfusion. They're much more sick, they're much more complicated patients, but again, they have severe or critical aortic stenosis, so giving them transfusion, giving them a huge fluid bolus is not without risk. And so I think it's important, if we can, to look at what practice is in America for these patients. I'd like to say thank you to my mentors for these projects, Sunil Rao, Eric Peterson, and my collaborators at Yale. And I'd be happy to take questions at the end if that makes sense. We will need.
So our next speaker is Julie Autmizguine, and Julie came to us from Canada, where she did her pediatric residency and pediatric infectious disease fellowship at the University of Montreal. While she was here, her research focused on the pharmacokinetics of a number of antimicrobials in infants and children. She was involved in the development and ongoing success of the two largest trials in the Pediatric Trials Network, the SCAMP study and the POP study. She had several research mentors while she was here. She worked with myself, Mickey Cohen-Wolkowitz, and Danny Benjamin. And then this summer, actually tomorrow, Julie's returning to Canada where she'll be taking a faculty position at the University of Montreal. And the title of her talk is Anaerobic Therapy in Premature Infants with Necrotizing Enterocolitis.
Thank you, Brian, for the introduction. And thank you, DCRI, for keeping the challenge and the expectations until the last minute. I am leaving tomorrow morning. And I will talk about some of the works that I've done in the past 2 years about anaerobic therapy in premature infants with necrotizing enterocolitis. This not works. I have no conflict of interest to disclose. And the objectives in this talk will be to first talk about an observational study of anaerobic therapy for infants that had NEC, and then go on with how can we validate or study those drugs in a prospective trial, and first, how do we select dosing for those trials, and I'll talk about an ongoing prospective safety trial here at the DCRI. So to start off, necrotizing enterocolitis, for those who are not familiar with this disease or this condition in premature infants, is a devastating complication for premature infants that is associated with necrosis of the gut due to a combination of multiple factors such as abnormality in the vascular tone, abnormality in bacterial colonization, immaturity of immune system, and probably secondary bacterial overgrowth, and maybe infection is not the trigger, but there's certainly a key, the bacteria have certainly a key role in the pathogenesis. And so the treatment usually involves antibiotics. And it's quite frequent, up to 15% of infants that are born with extremely low birth weight, and up to 50% of infants that have intestinal perforation. And for the so 50% of infants who had intestinal perforation die. And for the survivors, one of the complications is intestinal strictures, which leads to intestinal obstruction due to scarring after the NEC episode. And so, as I said, treatment involves antibiotics, and this is what we call the rainbow graph. It's from the pediatrics database, in which each bar represents a site, a neonatal intensive care unit in the United States. And we can see the use of different antibiotics, and we can clearly see that there's no consensus on which antibiotic to use for necrotizing enterocolitis, and we're facing a problem. We don't know the efficacy, and we don't know safety of those drugs. And among all those antibiotics, some of them cover anaerobes bacteria. It's a subset of bacteria that we have in our, premature infants have in their guts. And the question that I had was, should we prescribe anaerobic antibiotics on the first day of necrotizing enterocolitis? And it has been described that anaerobic bacteria play a role in NEC. It has been isolated in peritoneal fluid and in blood. And there is one randomized control trial in the late 80s that addressed the specific question whether infants with NEC should receive clindamycin, which covers anaerobe bacteria, or not. And so infants were randomized to receive infants with NEC were randomized to receive ampicillin and gentamicin with or without clindamycin. And this small trial, only 42 infants, did not see any benefits of clindamycin in terms of mortality or intestinal perforation, but did notice a large increase of intestinal stricture with a risk ratio of 7. And so that was part of our question. Is anaerobic therapy associated with this kind of adverse event? And so in the study that I conducted here, my objective was to assess the association between clinical outcomes and anaerobic therapy on the first day of NEC for premature infants. For this study, we used the pediatrics database in which, so the pediatrics medical group maintains a database that captures prospectively information from notes from physician of all infants cared in those centers. And it's a large representation of the NICUs in the United States. And so we included very low birth weight infants, which are infants that are born with a birth weight below 1,500 grams. And we looked at those who did receive anaerobic therapy and those who did not receive anaerobic therapy on day one, again, of NEC, regardless if they received it later. It was to mimic an intention to treat trial. And because we thought that infants that did receive anaerobic therapy would be sicker, we tried to minimize confounding by indication by using a propensity score method. And so the propensity score is the conditional probability to receive anaerobic therapy based on a set of clinical characteristics such as gestational age or severity of illness like ventilation support, oxygen support, and vasopressor use. And so we used that propensity score to match those who did receive and those who did not receive anaerobic therapy, hoping that they would be more similar. And then looked at our outcome, which was in-hospital mortality or intestinal strictures, both as a combined outcome and as individual outcome. And we looked at those outcomes using a logistic regression condition on the pair, on the matched pair. The cohort, the initial cohort included 6,700 very low birth weight infants with NEC, with approximately 75% of medical NEC and 25% of surgical NEC. And this medical and surgical, basically the severity of NEC, which is assigned by the physician in the pediatrics medical group. And it's a judgment on whether the necrotizing enterocolitis needs or doesn't need surgical treatment. It doesn't necessarily mean that they had a surgery. And so this, again, this judgment on severity of NEC was on day one. Everything was on the first day of NEC. And when we looked at the demographics between the two groups, those who receive and those who did not receive anaerobic therapy in this initial cohort, unmatched cohort, demographics were fairly similar, but we could see that those who received anaerobic therapy were sicker with more use of ventilator, vasopressor, and oxygen, for example. And so we proceeded to the matching based on the propensity score. And this matching resulted in a cohort of 2,700 infants, with 50% who did receive and 50% who did not receive anaerobic therapy. And just before we move on to the outcomes, if we look at those who received anaerobic therapy, what kind of antibiotics did they receive? We have here the percent of infants against the year, and we can see that clindamycin, despite this trial that we had in the late 80s, is still one of the most frequent antibiotic used for anaerobic coverage. And the second one is metronidazole, and then piperacin and tazobactam. And I think this also reflects that the lack of data that we have in the literature. Like, despite this randomized controlled trial, we don't know how safe or how efficient are the other drugs either. And this is these are the demographic and clinical characteristic of the matched cohort. And we can see, without going through all the details, we can see that gestational age, birth weight, and also clinical characteristics were well balanced after matching and were similar between the two groups. And now for the outcomes, I forgot to tell that when the matching occurred, we stratified matching by neck severity. So we matched medical neck together and surgical neck together. And but first, we'll go over to the first part of the table and the overall cohort, and we can see that there were more deaths in the untreated group, so the group who did not receive anaerobic therapy, but that was not clinically statistically significant. And the strictures were more frequent, again, in the anaerobic therapy group, and that was statistically significant. And then looking within each subgroup, for the medical neck group, death was very similar between the two groups. And again, we noted a slight increase in strictures in the anaerobic therapy group for the medical neck. And then interestingly, for the surgical neck group, we did observe statistically significant a decrease in mortality in the anaerobic therapy group. So it seems to be a benefit of anaerobic therapy for infants who present with a more severe neck. And again, and although the numbers are really low, again, we observed increase in strictures in this group without being statistically significant. This observational study is currently the largest study assessing the impact of anaerobic therapy in infants with neck. And the overall mortality that we observed of 23% was consistent with the previous literature. And this new finding that we observed a decreased mortality in infants that present with a surgical neck. The incidence of intestinal strictures, though, was in the lower range of what has been reported in the literature. And I think this is partly because of inconsistency of strictures definition in the literature. And so we consistent with the previous trial, we did observe an increased risk of strictures. However, put against mortality, for surgical neck, we had less than one additional stricture for each life saved. So it feels like anaerobic therapy is still there is evidence to support it for infants with surgical neck. And just going back to this randomized controlled trial that had clindamycin or no clindamycin, infants in that trial were excluded if they had intestinal perforation in the first day of randomization. So basically, the cohort of this trial is more comparable to the medical neck group of my study, which is consistent again with what they found: no benefit in mortality, but an increased risk of stricture, although their effect size was much larger. And so, as I said, I think based on those results, right now we can recommend anaerobic therapy on day 1 for infants who have surgical neck, but because in infants with medical neck there were no benefits and a slightly increase in harm, then I think for those infants we shouldn't start with anaerobic therapy. And so the next step to me would be to look at safety and efficacy of those antibiotics, but individually, because now they're all lumped together in this one group, anaerobic therapy. And I think we can't avoid we have to go through a prospective trial to really see the relation and the temporal relation between adverse events and therapy. And so how, of course, as you may imagine, we can't randomized thousands of premature infants with necrotizing enterocolitis in a phase 3 trial, right? And so interestingly, in 1994, the FDA proposed an alternative approach to increase efficacy of pediatric drug development and maximize available adult data. And so for conditions that we think are similar to adults. So for example, necrotizing enterocolitis, even if the trigger is not the same as intra-abdominal infection in adults, the resulting clinical condition is similar. We have intestinal perforation, peritonitis, and we have the same bacteria. And because the drug target a bacteria and not a physiologic process, then we think that for necrotizing enterocolitis, we could eventually extrapolate efficacy data from older children that had intra-abdominal infection or adults. However, we cannot extrapolate safety or dosing. We have to really look at pharmacokinetic data to see what is the best dose and, of course, the safety profile of these drugs. And so for necrotizing enterocolitis, we wish to adopt option C, which is complete extrapolation of efficacy data to support drug therapy in necrotizing enterocolitis. Whereas in other conditions that are specific to children, that we would have to do an efficacy prospective trial. And so in the Pediatric Trials Network here in the DCRI, led by Danny Benjamin with Catherine Berenzi, they have started to look at those drugs that I looked in the observational study. And they first conducted early phase trial PK studies to really determine what's the best dosing for those drugs. And for ampicillin, clindamycin, metronidazole, and piptazo, which are all drugs that are used in necrotizing enterocolitis. And just to give you an example, the kind of results that we get for clindamycin, for example, from the POP study, the POP study is a multi-center study in which children receive a list of drug of interest, including clindamycin, per standard of care, and the protocol only collect PK samples. And based on this study, we can define the PK of clindamycin and see, for example, here that the rate at which the body clears clindamycin increases with age, and that approximately at 44 weeks of postmenstrual age, clearance reaches 50% of adult clearance in infants. And based on those PK models, we can even predict what will be the exposures. And so if we know that, so here is the AUC, the area under the curve of clindamycin in the blood. And we can say that for adults, 70 kilo adults, 600 milligram reaches a certain AUC. So we can say that in infants, a premature infant, we need 5 milligram per kilo to reach that, to target that MIC. And so based on those models, we can recommend dosing for a prospective trial with good evidence. And so I had the chance to work on this ongoing prospective safety trial, SCAMP, which looks at safety of antibiotics in infants with necrotizing enterocolitis, in which 300 infants will be randomized into 3 different groups with different antibiotics combination across 50 sites. And the study is now enrolling. And of course, the primary outcome will be safety with adverse event of special interest. And of course, we'll also look at efficacy of those drug regimens. We'll confirm the pharmacokinetics that we did in the early phase trial, and we'll also try to identify some biomarkers and also other secondary outcomes for necrotizing enterocolitis. And so that was the, as I said, part of the work that I did in the past 2 years, which was really a combination of observational studies and clinical trials trying to maximize drug therapy and increase evidence for safe and effective use of drug in infants. And if you haven't seen this video on the first year of a premature infant, I highly recommend it to you. It's a short video, and you can have a grasp of the emotional roller coaster of those families that have such premature and vulnerable infants. And I thank you very much for your attention, and I welcome your questions. And I welcome the team that I worked with here, my mentors, and the PT and the Pediatric Trial Network team. Thank you very much.
It's funny. Very similar things.
So, great presentations from both. And actually, I'll start with just a softball question to each. So looking back on your 2 years, what's the single thing that you would change or do differently for the research fellowship? And then actually have some hardball questions about your actual research.
That's a great question. Honestly, some of the projects that I undertook are incredibly interesting, and I think I guess one of the things I would change is maybe looking at a little more focus in some of the projects that I undertook, because they were on a huge variety of fields. And when I think about what I'd like to do with my future research, I think to myself, well, maybe I could have said yes to a different project and said no to other projects just to be a little bit more focused. But honestly, it was a lot of fun working on a wide variety of different science, and I really enjoyed it.
I think what I would have changed, and I think it's in all in my future academic life, I will have the chance to do that, is to try to take on the challenge right away and not be scared of not being able to do it, or and just take on the challenge.
I'll let you ask her the hardball questions first. Here you go.
Well, actually, I mean, there are two common themes I saw in both your presentations. One is the use of observational studies and analysis and approaches trying to address confounding, and then also the consideration of trials to actually consider what the answer is. So I guess for both really, what do you think is the real answer? So for instance, the concerns about in pediatrics about adult dosing and disease and so forth, and using extrapolation from adult populations or observational studies, how do we actually get to that right answer? And similarly for the transfusion area, some of the things that you described seem potentially hard to do in terms of getting centers to restrict to certain transfusion parameters, and/or what incentives there should be around those. But so what's the final answer? A trial or outcomes?
I think the combination of both, proposed by the here in this presentation is the answer, especially in this vulnerable population where we can't, conduct phase 3 clinical trials. So I did the exercise and to detect, a difference in outcomes that I saw in my observational study in a prospective randomized controlled trial would require 7,000 infants, premature infants with necrotizing. So I think even if the right answer would absolutely be in the clinical trial. This is not feasible, and I think the approach of combining outcomes and rational use of clinical trial is a good answer for the real world.
I think it's a great question and highlights how hard some of this research is to do in terms of difficult clinical questions and how to answer them. For the transfusion problem, I've thought about it before and trying to utilize the variation that we see across hospital centers in the United States. And so for that, I do think randomized trials are the way to answer the question, but I think cluster randomized trials might be easier, because you could actually utilize sites' predilection to using certain transfusion thresholds, and that's the way they practice already. And you could say at your site, you're going to do this. There's a lot of equipoise. We really don't know the answer for acute coronary syndrome patients. So you could, in fact, say your site is going to honestly continue the practice that you have using 10 grams per deciliter threshold. Then we're going to take other sites, and they're going to use an 8 grams per deciliter threshold, and trying to control and randomize site for site. But I think that's one way to answer the question. Now, it's not as clean as randomizing patient by patient, but I think it provides a more realistic approach to how you could do it. Looks good, thanks.
Actually, one follow-up question about the transfusion is, there's been this discussion debate, old versus new blood. Were you able to look at that?
That's a
is
great,
that possibility?
great
Certainly
question.
FDA interest.
Yeah, it turns out that what Dr. Hernandez is referring to is that, and there is some data coming from Duke, there are studies looking at using blood that's less than 7 days old, between 7 and 14, and greater than 21 days old, and looking at outcomes based upon the age of the blood that you're transfusing for a certain indication. But what happens is that as blood is stored, it loses this 2,3-diphosphoglycerate. That means that it actually increases its oxygen affinity, and that means that it holds on to the oxygen and doesn't provide oxygen as well to the tissues that it's subtending. And so the other thing that happens is that it's depleted of nitric oxide, and nitric oxide is incredibly important for vascular health. And so as blood ages, it becomes less and less able to act like the blood that's circulating in your body. We were not able to look at the age of blood used in the CathPCI registry. That information is not available. But I agree with you, it's an incredibly important factor. And there are studies ongoing at Duke, not specifically for coronary or artery disease patients, but looking at the age of blood and whether the age lesion or the hit that you take with having blood stored for more than 21 days is actually clinically significant to outcomes.
Great. I guess we'll have to give you guys a pass and let you get your flight tomorrow.
Thank you very much.
Put the slide with the CD, but thank you, you too.